Hey everyone, Dr. T here, coming to you day one post cycle 4 of chemo, doing okay. Thanks for all your well wishes. Today I am going to have a little chat about two big topics that were DM'd through to me. The first one is looking at PGT-A, looking for abnormal chromosome number, and a little discussion around that. And the second one, obviously, is all about elective egg freezing. So if those topics are of interest to you, then strap yourselves in and get ready. I hope you guys have been well. Now, let's just talk about PGT-A. So there is pre-implantation genetic testing of embryos that people can do if they are wanting to determine certain things about their embryos. And I have talked about this before. So PGT-M is looking for gene mutations. So that might be something like CF, for example. A husband and a wife could be both cystic fibrosis carriers, and there is a 1 in 4 chance that a child of theirs could be born with CF. So they are wanting to see if the embryos that they create, any of them actually are potentially going to have cystic fibrosis. So that's PGT-M. PGT-SR is where we look for structural rearrangement. So that's where chromosomes might have crossed over each other. So all the genetic material the parent has, but unfortunately when the chromosomes split, these two segments can go either way, which means there is an unbalanced amount of part of a chromosome, and that can cause a child to be born with a syndrome. So that's another thing we can test for. But PGT-A aneuploidy is where we are testing chromosomes for an abnormal number of chromosomes. The most common one we know about would be Down syndrome, which is trisomy 3 of chromosome 21. And as many of you know, those children are born with very characteristic syndromes and varying in severity. But there are lots and lots of other chromosomal abnormalities. There's Turner syndrome, where they're missing one X chromosome. There is trisomy 13, there is trisomy 18, too much of 13 and 18, and they can also make it to a live birth as well. Often they have an extremely short lifespan. And there are lots of others. Most chromosomal abnormalities will miscarry, and we can detect if that particular fetus had a chromosomal aneuploidy by testing the products of conception. But we can also actually test embryos before they're even created. Now, the question that I was asked with that backstory was, this particular person is reading on a lot of chat groups that PGT-A is really discouraged by some clinicians. And there is certainly some pros and some cons to pre-implantation genetic testing of embryos for aneuploidy. I really like in WA how we have limitations who can access PGT-A. So for example, a couple where the woman is over 35 are able to access it, anyone. Under 35, you have to have a really good reason. So PGT-A under the age of 35 would be for perhaps a woman who has had 3 or more miscarriages, or who has had IVF with embryos created and 3 or more of those have been put back and they're not conceiving. So we then have the ability to move into testing, well, is it an embryo problem, and doing PGT-A. But we can't just indiscriminately do it for anybody here in Western Australia. And I kind of like that there are certain boundaries placed on this, because I do think that PGT-A for some couples may not be very cost effective. Why is this so? Well, we know that PGT itself at some stages of an embryo can be problematic. So it used to be that we would take one cell out of an embryo at cleavage stage, which is that approximately day 3 period when there's about 8 to 10 cells. we would take one cell and that would be representative of the entire embryo. Now, we did find out that that was harmful for embryos, so that's why we moved to testing day 5 embryos, where there are some 100 cells. And by day 5, or rather blastocyst, we know there's an inner cell mass forming, and then there is that big sac, the blastocele, and then there are the trophoblastic cells on the outside, and it's from the trophoblasts that we are taking that biopsy, and we take somewhere between 5 and 10 cells. Now, there is some evidence to show that perhaps maybe there could be an asymmetry in where abnormal cells are found, and perhaps they're confined to the trophoblastic tissues, so that when you biopsy those cells and send them off for analysis and they come back suggesting that that embryo is abnormal, well, it could be that that was confined to those tissues which will make up the placenta, and in fact the embryo was perfectly normal. So there are some clinicians who say, that's no good. We have the potential that we are discarding chromosomally normal embryos. Now, there is great discussion and conjecture around this. So I can tell you right now that there is no hard and fast rule. And in fact, most of the research suggests that confined placental, so those trophoblasts make up the placenta, confined placental mosaicism or chromosomal abnormality in some cells happens in only 1% of cases. And in fact, there seems to be quite symmetrical distribution of abnormal chromosome numbered cells throughout both the embryo and the trophoblastic tissue. So in fact, that argument for not doing it and just transferring embryos is not really all that robust, and there's argument against that as well. So I think that's important to have as part of the discussion. Can you have a false positive result where it says that it's chromosomally abnormal and yet the embryo is normal? Yes, but in some 96% of cases, and it does depend on the lab that's being used, the test is highly accurate. However, we do always suggest that you actually go and have some confirmatory testing. So, at least NIPT. But again, that tends to come from the placental tissue. Probably more amniocentesis is going to be representative of that embryo. So that's a really long answer to that question. But there are other things that are really important to think about with regards to genetic testing for chromosomal abnormality, or PGTA. It actually doesn't improve the chances that that woman is going to eventually become pregnant. So if you create 5 embryos and you test them, it might come back that 3 of them are normal and 2 of them are abnormal. So you've saved yourself potentially 2 transfers. But if you had just transferred each of those embryos, eventually somewhere in there you will conceive. So it doesn't actually reduce the absolute pregnancy rate or the cumulative pregnancy rate. It probably just improves the chance of pregnancy at that next transfer. But remember, when you're testing, you are actually having to have a month off while the testing results come back. You don't get a fresh transfer. So you're really not achieving a transfer until month 3. So there is that slight time delay. What it does help, however, and this is a big thing for some people, it does help reduce that time that you have to get pregnant, progress along a few weeks, finally do an ultrasound and find there's no fetal heart, for example, let's say week 7 or week 8, and then have to go through the very distressing termination of pregnancy, or even just having a miscarriage at 7-8 weeks. So it does reduce that time delay to falling pregnant and having an ongoing pregnancy. So that's just a bit of food for thought. It was a great question and I wanted to spend some time answering it. And most certainly I have not answered all of it, but it certainly gives people food for thought and consideration about PGTA. The other question that I have that has been raised, and I really want some discussion here, so feel free to jump in and add something to the comments about elective egg freezing. Many of you would have seen the segment that I did on 7:30 Report ABC. Thank you very much to Rhiannon and Shine for giving me that opportunity. It was really great. And it is something that I am really, really passionate about. So the statement really came back to me. Everyone should have access to egg freezing. And absolutely, hand on heart, I completely agree that everybody should have access to understanding and informed consent about elective egg freezing. So I want to clarify, there is egg freezing for medical purposes. So that would be something like me, if someone was going through a chemotherapy, we know that is injurious to eggs and reduces ovarian reserve. So absolutely, that's medical egg freezing. Perhaps someone has had multiple dermoid cysts in their ovaries, and so their ovaries have been destroyed or are in the process of being destroyed by surgery. Again, someone to be considered for medical egg freezing. Perhaps somebody has had a condition that has led, such as Turner syndrome, which has led to a significantly reduced ovarian reserve, and so they might be accessible to elective egg freezing, or perhaps some other genetic mutation like BPES. So there are definitely groups of people where egg freezing is medically indicated and therefore funded partially by Medicare. The rest of us, it's considered elective egg freezing, and right now there is no Medicare benefit to that. Doesn't matter how old you are. So it is up to you guys to be advocating to government to do this. Do I personally feel everyone should have access to Medicare funded egg freezing? I don't think so. And the reason for that is there's only so many Medicare dollars to go around. So if I was, having a consultation with a 21, 22-year-old young woman who was wanting to freeze her eggs, and she had a good egg reserve, do I necessarily think that should be Medicare funded? No, I personally don't think it should be. But there needs to be some sort of threshold, some sort of cutoff that really shows that this particular woman's reproductive potential is likely to be compromised. And that should be considered. And I believe we need some national guidelines, because unfortunately for fertility specialists like me, we are kind of left to make the call ourselves. And whilst some can make a very educated decision because they're interested in this, there are some who may not. And so I really do think we need to have some better nationally determined guidelines and industry determined guidelines. And that's a work in progress. I also want to draw attention to the fact that 1 in 10 people do not come back to use their eggs. So that's a huge investment for them. That's an investment in their cycle itself. So the equivalent of IVF. It's also an investment in the storage fees, and the storage fees can accumulate. So if you think a 25-year-old goes in to freeze her eggs, she's paying $500 a year for storage and is highly unlikely to consider using those eggs until over 35. That's more than 10 years, more than $5,000 just in storage fees alone. That's a lot of money, and for no 100% guarantee. So that's the other thing. All egg freezing does is overcome the elective egg freezing, overcome the impact of age-related fertility. So what if she were to have a partner who had terrible sperm? What if she later on in her life developed endometriosis? Egg freezing is not going to overcome those pathologies associated with infertility. It will only potentially overcome the impact of age. And there's no 100% guarantee. Her eggs may not survive the thaw. It all depends on which lab she went to, how experienced they are at egg freezing, what equipment they use. Do they use slow freezing or vitrification? Most labs do use vitrification now. But there are all these questions that remain essentially unanswered because we do not have any Australian data on this. So I really wanted to talk about those things because I think the education component of this is absolutely essential. And the person who sent me the DM, thank you so much for bringing up these questions. And I think more and more of us should be discussing this. And if you have any thoughts on this, I totally would love you to drop it in the comments and we continue having these discussions, because the more knowledge you guys have in your hands about egg freezing, the more empowered you are to making a really considered decision. All right, I do have one question that is in the chat group, and I will have a quick read. Any tips on telling kids how they were conceived, i.e. to... Oh, yeah. Yeah. Look, don't worry. As a mama, I always have a thought about that. We certainly know with egg donation, and the data is all around this, there is great information about telling children early how they were conceived and really normalizing it, really normalizing the process. There is a great book, and for the life of me, I cannot remember the title, but it's written by Cassie Silver and her husband. It's relatively new. It's a children's book, and it is about conceiving a child via IVF. And it's a beautiful little story, and I'm happy to give it a plug here, because I do think that these are the sorts of resources that are needed to have the general discussion about how kids are conceived. So I don't have any absolute advice. I do think earlier rather than later. I do think normalizing the process and talking about this. And look, having these conversations with all young people is really important, because what we've realized as this generation of women, as we get older, is we had a lot of discussion about contraception, but we never had a lot of discussion about fertility. And as a result of that, we have this increasing number of people who are accessing IVF for age-related infertility. So, hopefully that is a good answer, but certainly starting to have conversations around that sooner rather than later is good. All right, guys, I think I've outdone myself. A little bit of an update on me. I have just completed my 4th round of chemo. I'm feeling pretty good, just very fatigued today, as usually is the case in the days after. A little bit of brain fog, but it's not working too bad today, actually. And even my oncologist was surprised that I still had my hair. He was certain that I would be bald by now. And I don't seem to be losing too much, just a little hair around the temples. But apart from that, who knows? I might just be able to rock the G.I. Jane look for a little bit longer. I hope you guys have a beautiful week. I hope some of that information was really helpful. And don't forget to join me next week. All right, have a good one. See you later.